So the 9,600 people or 9,200 people that didn't get transplants, what is the success rate probably of those? So we're saying they're now on dialysis.
Mm-hmm.
So maybe 60% of them may have survived it, but that means that 40% did not.
Mm-hmm.
Is that correct?
Well, I can tell you in 2024, 4,600 people died while waiting for a kidney transplant.
Mm-hmm.
So we
half
threw
of the
away
9,200.
9,200 organs,
Yeah,
and
that's half
46
of
of those
9,200.
patients died.
So if we lowered the risk appetite, if we're able to do that, so that means that we could get almost all of those 9,200 out there to people. And if we had an 80% success rate, that means that now we've saved 3,000 more lives, something like that.
Yep.
Does that sound right, guys?
It does.
Mm-hmm.
Yep. And for some data, the USRDS says that the latest 5-year survival rate for the in-center hemodialysis is 40%. So to your point,
Wow.
Kyle, that is a very low 5-year survival rate.
Yeah.
And knowing that those discarded kidneys, if we would have altered the threshold, changed the appetite, could have prevented many of those deaths.
Hey guys, let me just make something clear here. Again, I'm not a healthcare expert, but we're not talking about trying to transplant junk. What we're talking about is some of the standards may be a little overboard in terms of what is good enough to have a quality transplant occur. Is that what we're saying? That some of the standards are maybe too rigorous, where more organs could find recipients if those couple things were just lowered a little bit. Isn't that really what we're saying?
I think an adjustment to the overall standard to meet quality. We don't ever want to reduce the standard when it comes to quality of the organs, but what we want to do is increase the overall survival rate. And if there are organs that are meeting, whatever this new standard is, if they can adjust it or put it in a way where patients can get these organs, it would definitely increase their overall likelihood of survival. I think the hardest thing is because the standard is so high, we have physicians that are not willing to take the risk of utilizing these overall organs if they're not meeting the quality standard. That being because if the patient does not survive, that can be a ding against the physician, but also against the hospital. Is that correct? How we understood it?
That's
in
what
conversation.
That's what I understand, is to use Kyle's words, the misalignment, right? So we're not aligning with what quality from the patient's perspective is, what quality from the OPO's perspective is, and what quality from the transplant center's perspective is, right? The patient's perspective of quality is better than a 60% chance of dying.
Yep.
And right, that is their perspective. We need to take that into consideration. Every other facet of healthcare, we give patients informed consent and allow them to be a part of that risk discussion into their care. My opinion is that we should be doing that with these things, right? There's design, there's regulations that account for all of that. There can't be, we advocate all the time, stop being siloed, get everything, there's much more intelligently interconnected. And it's not just for our internal processes, it's for all of the impacting. There's regulations, accrediting standards. To Kyle's point, even how the hospital is compensated, there's on the transplant center side, adjusting those so that there's greater incentive to bring more, kidneys, say, just using that, to the patient to say, are you willing to accept this? Have them do a high risk disclosure. I understand that this is, there's just like we did back in the day with HIV, hepatitis, or other high risk, there's social determinants of health. We gave them a high risk disclosure and said, you know what, there's a chance that you may contract an infectious disease or that this graft may fail, but we gave them the option. And I feel like we're not respecting patient rights in this scenario by not giving them the option.